Good day. I'm Thien Thien. I'm the social media editor of the Parkinsonism and Related Disorders journal. Today, we have Dr. Safarpour here with us for a short interview on her recent published article entitled Consensus Practice Recommendations for Management of Gastrointestinal Dysfunction in Parkinson's Disease. So, what sparked the idea of developing this consensus practice recommendations for the management of GI dysfunction in Parkinson's disease?
Hi, and thank you for having me. I'm one of the movement disorder specialists at the Oregon Health and Science University in Portland, Oregon, United States. I work with a group of wonderful experts in our practice in taking care of patients with Parkinson's disease. Very commonly these days in care of patients with Parkinson's disease, we use an interdisciplinary approach. Not only GI dysfunction will impact quality of life in a negative way, but also it will directly impact absorption of the medications, symptoms such as gastric emptying, delay, SIBO. So we decided to come up with a paper that is easy to read, not for the neurologist and movement disorder specialist, but also for primary care and gastroenterologists taking care of patients with Parkinson's disease. We decided to come up with bullet point references for those who take care of patients with Parkinson's disease to say how to take care of each symptom and what are the things that they need to think about, what is screening they need to do, and how to follow it up. Symptoms such as drooling, swallowing dysfunction, nausea, problems with constipation are significantly more common in patients with Parkinson's disease. And we have learned from major studies that the hallmark of Parkinson's disease, activated alpha-synuclein deposition, can be found in different segments of the GI tract. And therefore, it makes sense that if the pathology exists and years before onset of clinical symptoms.
Very nicely written, and in fact, very easy to read this consensus review paper. What are the common GI manifestations in PD that you would like to highlight?
Yeah, so the different GI manifestations that we covered here, we started in the oral cavity, went into the esophagus, stomach, small intestine, and colon, and assessed each of them separately. As an example, I'll talk to you about what we had for consensus for drooling, for example, because drooling is very common. And what we suggested here is that in case centers are thinking about having questionnaires to examine progress of these symptoms over time, we suggested in our first statements, these are the questionnaires that you can include in your at least annual examination of your patients, so you know how these symptoms are changing. For drooling, we're asking about symptoms of dysphagia. Is this drooling just during the waking hours or just at night, or is it drooling plus swallowing dysfunction? Is it impacting quality of life? And when do you suggest treatment? Sometimes optimizing medications enough will be good for management of drooling. We suggest some medications, and if these don't work, we have suggested that they can consider botulinum toxin injections.
How would you advise the practicing physician treating Parkinson's disease to make use of this consensus paper?
So the way they can make use of it is if you are in a very busy clinic and you really have time to know just bullet points about what to do with that symptom. It is, we broke it down into different segments, so just go to that segment. So this is what my patient's problem is, constipation, for example. This is what I should do, and this is when I should refer to another practitioner. And then after the statements are presented, we go into details of, so what's the evidence, what are the studies that have been done here, and what is still missing.
Great. Let's take, for example, constipation, one of the most common non-motor symptoms of Parkinson's disease. How would this consensus guide us?
The first step, reviewing other comorbidities, other comorbidities such as hypothyroidism, diabetes, a lack of mobility. They don't walk as much, they don't drink water as much, and these are all the reasons that could lead into constipation. Then go into over-the-counter medications and start suggesting those medications. Over-the-counter medications, some of them can have some side effects. So for example, if you have a patient who already has a lot of bloating, you don't want to start with Metamucil. That can possibly make it worse. Maybe consider Miralax instead. When patients don't respond to these over-the-counter medications, you can consider prescription medications, but this is where you also consider a referral to your gastroenterologist to see if manometry is indicated, if this is a defecatory dysfunction, or there's more layers of dysfunction than just transit difficulty for this patient that needs to be addressed. When it comes to pro-motility agents, most of our practitioners know, but medications such as Reglan should not be prescribed for patients with Parkinson's disease, should directly be avoided because they can cause worsening of Parkinsonian features. And so other agents that are available to us, one of the good ones that is approved for constipation is Procalopride, that can not only help with the motility in the colon, but also motility in the stomach. So it's good for a number of our patients with Parkinson's disease. And then when will you consider pelvic floor and biofeedback, that together as a combined method that can be very helpful in patients who have constipation. Very commonly, the neurologist needs to collaborate with the primary care in management of the other comorbidities, the medications that can cause constipation, also knowing when to, in a timely fashion, get the gastroenterologist and the rehabilitation services to work with them to improve quality of life for these patients.
Wonderful. Thank you so much for this interview. It is a great paper, and I'm sure all the readers will benefit from this consensus review article.
Wonderful. I sure hope so.